So I just want to tell everybody thank you so much for joining us today. We have Dr. Browning here, and I think his fellow audiologist, Dr. James Gibson, is also going to be joining and kind of helping out. Um, they work out of Central City, Litchfield, the Madisonville area, and they've worked with our consumers for years. And they have agreed to jump on here, give a presentation to kind of talk about um, the consumers, what they experience when they go for hearing tests, how hearing is measured, various things like that. So if you have any comments, questions, you can always ask those, or you can send a message in chat, and I'll be happy to relay that. But Dr. Browning, I'm going to turn the floor over to you.
All right, real quick, let me get this off the record. I am the last year that Louisville put through the doctorate program. So I'm the one of the old dinosaurs that had the that's still listed as a clinic, as still listed with the masters. So I want to make sure I don't get called into the doctor realm when I haven't, when I'm 6 weeks, I think, short of it. So anyhow, I want to get that off the table. Thanks for the introduction, Ashley. I really do want to give everyone a feeling of what happens when they come through the door. We we have a when they arrive there, we have our receptionist will take in the paperwork and we'll do they'll get the clinical analysis form and give us as much information as they can. Um, we'll get their insurance and we'll let them know before they really get comfortable what's going to fall under their hands as far as financial, or if they've got insurance that covers, so they don't get any surprises as they go through the process. Once they come into my office, that's where I start probing deeper and finding out exactly why they're here. Sometimes they've been years before they come in. They've been my wives, kids, grandchildren, everybody's been on them, and they just don't think they have a problem. And they may be here just to see who is, uh, if they trying to find out if they own the problem themselves, if they're blaming everybody else, what the level of deniability is. And sometimes that's just it's just a conversation to see where they are. Other times they come in here and it's like it's the end of the world. They're just they can't do their jobs. They have trouble communicating at work. And it's oftentimes people will say, well, it's so loud at their work and everything. Why is it they need to communicate anyhow? And the thing is, they have meetings. They're trying to learn things, and we've got a ton of evidence already that says that people who have hearing loss get passed up for promotions and oftentimes don't even get hired. Uh, and I'd even go as far as to say they don't get past the interview because they just don't. People will read that as them being uh, just not being able to get it. They're slow. They have problems that will keep them from doing their job. So it's a huge thing, and we know with people with hearing loss, they make less money. They don't have as good of prospects of promotions. So these are things that you all really step in with us and help out a bunch, because it makes a huge deal to these people when they can get services and what they can do. So that's kind of what we do. We tell them that what the test is going to be about. It's going to be some beeps they're going to hear. We're going to do some pressure test in their ear. We're going to make it to find out if it's something that's a medical issue that can be fixed quickly. Is it something that's a permanent issue that can be fixed quickly, uh, or with amplification or something? Um, and then we start asking questions to figure out where we direct them next. So one of the first things we do is we find out. Well, I'll examine the ear and I'll say, okay, do we have any kind of a deformed ear? Is there a trauma that's been done? Is there anything that that could be where nobody's ever looked at before? And I'll ask them. I said, has anybody ever looked at this preauricular cyst or something? And they'll say, well, no. And I say, well, we might not get that looked at first. I'm going to check for drainage in the ear. I'm going to make sure that there's nothing that's actively affecting it. And most of the time, you don't see that because they know, and they're not here when they have drainage, but every once in a while I do. I'll look in the ear canal and I want to check to see if there's any earwax, or as it says here, cerumen, or see if somebody hadn't stuck a Q-tip in their ear or a ear mold tip, or I've seen everything from roaches to moss to cotton to foam to you can't imagine what comes out of an ear canal. Um, we'll check about if they're having any pain or discomfort. Dizziness is another thing. Dizziness and the hearing and the vestibular system are tied together. So we're going to have some of those things will cross over. And if there's a big dizziness issue, we may get that to an ear, nose, and throat specialist. I see a lot of those at the clinic when I'm working at the hospital. I'm going to skip one for a second. History or rapid hearing loss. If there's been a sudden loss in the last 90 days, then we really need to get them to the clinic, because that's something that may be active and still be treatable. Even though it looks like it may be permanent, it may be something progressive. It may become something that could recover, but we really need to see if they need to be on steroids or some type of medical treatment. And unilateral loss, if there's a loss in just one ear, not the other, that's recent onset, that's a big deal. That could be a sign of something else, some kind of a viral issue that still can be fixed. But if they're not fixed soon, they may not ever be fixed. So that's why our job is to get them to a ear, nose, and throat specialist as quickly as possible. And you'll see here on number 6, I've got written audiometric air bone gap equal to or greater than 15 dB. You all have seen a lot of audiograms, and if you've noticed, there's air conduction and there's bone conduction. And we're going to talk about that today, what exactly that is, because I'm sure most of you know what the air conduction is, but you may not know what those bone symbols are. So let's go to here. So once I get them back, I look in their ears and you can see, and I love these slides, they're really good, because that's exactly what it looks like when you look into the ear. You can see what a healthy drum is. It's translucent. You can see through it. The next one's impacted. You can see the way, and you can see how it's concave looking. That's typically where somebody has stuck the Q-tip down in their ear, trying to fish it out. And all they do is give it a concave look where it makes it almost impossible to get out.
So that would be when someone has a significant earwax block right there, that second image.
Yeah, they've created it actually, what they do. Yeah. The ear canal's migratory. Whatever's down by the eardrum, if you'll just leave it alone, it'll work its way out. Until you get, sometimes when you get old, the body doesn't purge like it should. So if it's trying to come out on its own and you're down there trying to fish it out, this is what you'll get. And it can be hard to get out when it's like that. That's why sometimes you have to be scheduled into the ear, nose, and throat office to have it done, cleaned out every 6 months or so. Canal bleeding, it's usually not from trauma. Again, it's where somebody who got creative and said, hey, I bet this bobby pin will work in getting this earwax out. So they get in there and dig with that, and next thing you know, they've cut the canal or scratched the canal, and you've got blood. Perforation is exactly what it looks like there. So many times I see these things, and that is it. It's just a hole in the eardrum, and you can see the little hole there at about 4 o'clock. Tube. That's what we want there. That's what keeps the atmospheric pressure equal on both sides of the drum. And the last one here is a middle ear tumor. You won't see that often, but occasionally, when I'm at the hospital, I sometimes see it.
I will say that we've had consumers, a lot of them that will come to us and tell us, when I was younger, I had a lot of infections and a lot of drainage, and I had tubes in my ears so much as a child. And that they'll talk about now having scar tissue. Is there a link between the two?
Yes, exactly. That's exactly, and it's just like you said, exactly like you said. It's actual scar tissue. And if you'll look at a drum, you can't see it on the slide very well, or it'd be up there. But if you look at the drum under light, you can actually see it's what we call a plaque. Really, it looks like it's got a whitish patch on the drum. And when the eardrum gets cut, when you're younger, because that's what you do, you put a slice in the drum and you stick the tube in. Those cuts, and some people have tubes 4, 5, 6 times growing up. So guess what? You created a lot of scar tissue. The eardrum doesn't vibrate well, and you have we'll get to that in a minute, a conductive loss. So, yeah, that's exactly what happens. And we start the very first thing we do, and if you all noticed on the audiograms, you will see what looks like mountains up in the corner. And they and what we're looking for is the pressure of the ear, pressure of the eardrum, where the eardrum is mid, if the eardrum is midline or not. So what we'll do is we'll take the probe on the tympanometer, we create a seal and change the pressure in the ear canal, and we can see how that middle ear is functioning. And when I say middle ear, I mean the eardrum itself. Now, the one that you all will mostly see is this one on the left side. Right over here. You see how it looks like a mountain? That's
Yes.
exactly what we want. We want it to be, this is a midline, this is atmospheric pressure at 0, and there's movement on the right side, there's movement on the left side. So if you could just take and push your eardrum, it would move a little bit, and then it would move back to the midline. And that just tells us we put pressure in, it moves and it comes back to normal. This will happen if you have normal hearing, and this will happen if you have a sensorineural or inner ear loss. What we're checking for again is function of the middle ear, not the inner ear. Now, you'll see the next picture down below it. We've got a what looks like no line, but it's actually a flat line. And that's when I push on the eardrum with the sound pressure, and I push on it, but the eardrum doesn't move. And I go, well, why is the eardrum not moving? And the reason is behind the eardrum is an air-filled box where the little hammer, anvil, and stirrup, as we learned in 8th grade, that's where it lays. That's an air-filled box. And if that box is air-filled, when I move the drum, it'll move. But if there's fluid behind the drum, we know fluid can't be displaced. So when I push on that drum, it's not going to move. And that's going to give me a type B tympanogram. Now that could be any number of things. It could be it could happen from fluid in the ear, the middle ear ossicles not functioning right, calcification, crack in them. It's hardening of the bones. It could be any number of things, and oftentimes that's treatable. So that will give us more likely a conductive or mixed loss. Now we go to type C. We push on the eardrum, but it doesn't move like I want it to at the midline. See how the mountain is straight up and down? Now we've got a rounded hump that's off to the left. So what that is, if you've ever gone up a mountain and you didn't Valsalva or you didn't pop your ears, then you're going to get up here and say, "Ow, this doesn't feel, my ears feel stopped up. My ears feel stopped up." Well, they're not really stopped up, but they are sucked in. The eardrum is retracted. It's sucked in. It's pulled in. So now we have to get that pressure equalized. And that's when we're trying to pop our ears and everything. And then you go, now it's good. But sometimes it doesn't clear up on its own. And it's kind of stuck there. So now we have to find out when I do the temp, is that going to be midline or not? And it's not. So I know I'm going to try to, while they're in the office, I'm going to try to get them to Valsalva. I'm going to try to get them to swallow, yawn, do whatever they can to pop the ear. If they can't, and it stays like that, then they may have something going on. That's something that's coming on. It could be maybe an upper respiratory infection. The eustachian tube's not working well, and the eardrum has negative pressure in it, and it starts pulling the drum back in. Or it may be something you've had an ear infection, or you've had an upper respiratory infection, and it's starting to cure itself now, and it's working itself back up to midline again. So it could be the resolution of something or the indication that something's coming on. So that's what, even before I do this test, I'm already can tell whether I'm looking at maybe something that's got normal, it's checking middle ear. It's normal middle ear function, abnormal middle ear function, or potential middle ear function. Now, I like this slide. This right here, this is the ear, of course, and this is the ear canal. Right here, this green thing is the eardrum. So there's actually 3 parts of the ear. There's the outer ear. The outer ear includes the outer ear and the canal and the eardrum. People come into the clinic all the time. I got fluid in my inner ear. Got fluid in my inner ear. They don't really have fluid in their inner ear. They got fluid in their middle ear. This is the green thing. Remember, I told you a while ago, I said you push the drum and it moves. What happens is the malleus right there, the hammer will move. It'll move the incus and it'll rock the stapes. And it will do that if it's air filled. If it's not air filled and it has fluid in it, it doesn't move, gives me the type B temp. So when they say fluid in the middle ear or inner ear, this is where it is. We don't want fluid here. What happens? This is that eustachian tube that goes to the back of your throat. It will close up, creates negative pressure. Nature abhors a vacuum. So next thing you know, we got fluid pouring in here. Now, when the eustachian tube doesn't work, what do they do to get the fluid out? Well, sometimes they'll put a tube in, and that's why they put tubes in, so it'll drain. But this thing right here is the cochlea, and it is the inner ear. And that's most of the people that you all see, probably 75 to 80% of them, this is what they have. They have an inner ear loss. So, 3 parts. You're either going to have a conductive, which is going to be where the bone, where this part's good, but this part isn't. Mixed, where this part isn't and this part isn't. Or cochlear or sensory neural, which this part here is good and this is not. And we'll go on a little further here, and I'll start to put it to how we're going to make it fit with what the audiogram shows. So when we test for hearing, we're going to put earphones on somebody. It's air conduction. It goes just through the outer, the middle, and the inner ear, just like we talked about. Each ear is done separately. You'll hear beeps, and you're going to identify. I'm going to say yes when you hear the beep, even if you barely hear it. And they will say, okay, yeah. Oh, just barely. And then when they do, I'm going to plot that on that graph you all look at. And I'm going to do it for both ears, and I'm going to find the softest level that they can hear sounds. And that's called a threshold. These are the thresholds. Once I do that, and I've plotted that on a graph, then I'm going to do bone conduction testing. This is where instead of a headphone, they're going to put a bone conductor on their head, or I'll put the bone conductor on their head, and it goes behind their ear to the mastoid bone, and it sits there with about 500 grams of pressure on it, and it just presses against the mastoid.
So that bone conduction testing, it's like a headset that you use?
Yes, but it doesn't go on the ears. It goes behind the ear.
Okay.
We're presenting it, and the brain, what it's going to do, and this is where it gets a little complicated. What it's going to do is it's going to bypass the outer ear and that middle ear. And it's going to go straight to the cochlea, that inner ear, straight to that cochlea, which is supposed to be fluid filled, by the way. So we're going to see basically if air conduction is better or worse than bone conduction. Air conduction and bone conduction in a normal ear should always be the same. In a pathological ear, air conduction and bone conduction, if they have a conductive or mixed loss, will not be the same. And we'll talk about that here in a minute in a little more detail. And then in the rest of the test is going to be, will be a speech test. And this is where we're going to find out, again, we're going to instead of beeps, we're going to give words. And we're going to see how well they can determine words that are spoken. Because sometimes you might present a list of 25 words and they may only get 15 of them. Even if I turn it up to where they hear perfectly. Then we're going to check, and I'll tell you more about that in a minute too, that we're going to check about what their most comfortable loudness level is, where they think loud sound normal and they hear well. We're going to see what their uncomfortable loudness is, how loud they can stand the sound before it actually, makes them kind of crazy and says, turn it down, it's too loud. And we're going to chart all of that on that audiogram. So the 3 things that audiogram is going to contain when you look at it in a minute is air conduction testing, bone conduction testing, and speech testing. Now, do you feel pretty good as far as where we are right now? Ashley, do you feel pretty good about that?
Yes, because
Okay,
we're looking at the audiograms. We have not only just the graph, but we have those little charts or the little bar
right.
at the number that has the different percentages and numbers, and that's kind of one of the things we look at, and sometimes that information can be a bit confusing.
It is a bit confusing. And I'm going to tell you something. It's confusing for doctors. It's confusing for nurse practitioners. It's confusing for a lot of people. So don't ever let it be overwhelming to you. It can be difficult, but we're going to hopefully clear it up a little bit.
But you never
Now,
rely solely on one assessment. You do a
nope.
combination of different
Yep. Cross
tests.
check. First thing they teach you, cross check principles. You need to cross check the tympanometer with the speech, with the bone conduction, with the air conduction, and make sure that they're all in agreement with each other. Because you got people who will fake a hearing loss. You got people who, have different cognitive issues and things, and you just have to be sure what you get is what you get. I don't know how many times we see audiograms come in and they're wildly wrong just because you don't cross check. Some of these people don't even do some of these tests. A lot of people don't even do some of these. Uh, but the most often though, I mean, I don't want to say all that happens often, but it does happen where people just don't do enough of the deep enough testing. Uh, Pretend that this graph here is an audiogram. You see the top here where it says normal hearing, mild hearing, moderately severe, severe, and profound. Without knowing anything, you can just tell that anything up on this graph is good, anything down is not. The further down it is, the worse it is. The further up it is, the better it is. So when you see like a circle here, 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 and here, we know that that's normal hearing. That person heard all the beeps as softly as they could at a normal hearing level. Now, so if you look at the left, you'll see that's soft, and as we go down, it's loud. So when you plot this on an audiogram, you're going to have the air conduction at either low frequency or low levels or bad levels. And you're going to plot it with this chart over here. Air conduction shows a red circle. Air conduction shows a X in blue or black. All that is you're doing air conduction testing with the right and left ear, and you're going to plot it on this graph. So you're going to start at a low or mid or low frequency. Let's say we start at 1,000 hertz, and I present a beep at 40 decibel. They hear it. I present it at 30 decibel. They hear it. I do it at 20 decibel. They hear it. I do it at 10 decibel. They don't. I go up to 15 decibel. They do. And I'm going to plot that right there with the red X in their right ear. Then I'm going to do the left ear the same thing. And when I get done, or the blue X, not the red X. And when I get done, I will get a test. Now, this is what you all have seen before.
Mm-hmm.
You'll get a test that looks like this. Do you see the circles on the top line and the X's on the top line? That's hearing within normal limits. You see these numbers up here that say 250, 500, 1,000, 2,000, 4,000. That's pitch. Pitch and frequency mean the same thing. So we start with the lower pitches and we go to the higher pitches. So it's like a piano keyboard you're looking at there. Everything on the left side of the keyboard is the low notes. Everything on the right side of the keyboard is the high notes. A while ago, I said anything up is good. We know that this is all good because everything's up. And we know there's no middle ear issues because the tympanometry is good. We got a good type A strong temp. This is as normal as what you could hope for. Person comes in, see you back whenever you have issues. When we did the speech a while ago, I told you we were going to present it. This is what this graph is here. Let me go back. I'll show you a better graph of the speech. Right here, this is blown up a little bit. We're going to give, when that patient sits in my office, I'm going to give them 2-syllable words. I'm going to say the word hot dog, say the word cowboy. Those are called spondaic words. It's equal stress on both syllables. And as I'm giving them the words, I'm turning it down. I said pork chop, birthday, sailboat, and I get down to like 15 decibel. And I'm going to write in there 15. right where it says speech threshold. Remember, threshold's the softest you can hear. So that's going to be the threshold, 15 decibel. I do that for the left ear. Same thing, spondaic words again, 2-syllable words, put it in, I get down to 15 again. Guess what? 15 dB and that 15 on that audiogram I showed you a while ago with the blue and red X are in agreement with each other. So I'll know that that's another cross check. When people lie on hearing tests, they don't lie as much on speech as they do on the beeps. So this is just another way we catch people malingering or trying to deceive us into making they think they hear worse than they do. Once I get the speech threshold, then I'm going to get to speech discrimination. And this is basically, like it says on the test, it's a monosyllabic word, single syllable. Excuse me. That it's a single syllabic word, monosyllabic word that they will repeat back to me at a level that they can hear. So it'll be turned up to about 40 or 50 above what their threshold is. So if our threshold's 15 decibel, then that'll be presented at 65 decibel or 55 decibel. So at that point, if they've got normal hearing, they should get 100%. And on our audiogram I showed you a while ago, they did. They did get 100%. So this is finding out how good they can do when they amplify speech. We find the threshold, then we find basically the most comfortable level or the level that they do best at.
So for those percentages on the speech discrimination scores, we see those a lot. Is it the lower the score, the worse their speech understanding is?
Yes. Everybody who comes in my office, they always see that number and they say, so I've got a 68% hearing loss. No, you don't have a 68% hearing loss, but when you hear conversational speech in isolation, not in running speech, but in isolation, you hear it at a 68% level. Like if I said, say the word pick, room, nice, said, fail, south, white, then they're going to give me those words that they hear back. And some of them will be just wrong. They just don't, what they hear is not what they thought it was because I've got my mouth covered. They can't read my lips. And the people who have hearing loss that work in your office or know a lot about it, they will know just how big a deal it is that you can lip read. Even with hearing aids, anything that you can do will help you to communicate better if you can see somebody's mouth. You get those tiny facial expressions and it just makes it so much easier. But yes, it's just a determination, and somebody who's got normal hearing, I would expect to have 100%. And we go back to the audiogram, and they do. We see right here 100% at a 40 dB sensation level. That means 40 decibel over, that means 40 dB over 10 dB. So we're presenting that sound at 50 decibel, and this patient got all 100 right. Their most comfortable listening level was 60 dB. And we use that a lot of times for if this person happened to need hearing aids. This person, of course, doesn't. But that's what we do to check and see if they need hearing aids. Now, if you'll notice, on this screen here, you see where it says bone conduction?
Yes.
Now you've got a red and a blue. Same thing again, bone conduction for the right ear, bone conduction for the left ear. Now this gets a little tricky, but follow along. Right in between all those zeros and X's, you'll see those little brackets there. Okay? That means, remember I said the middle ear was clear. So we know there's no conductive loss. So the bone is exactly on target with the zeros, with the air conduction. Does that make sense?
Yep. So the line that we see on audiograms is basically all those symbols is the results of the air conduction, the bone conduction
being
assessments.
equal.
Yeah.
Yes. And what that means, they're in agreement with each other. And this is where we'll go to the next audiogram. Now look at it. You see how the low frequencies there, right here, are all pretty close to normal. But the higher pitch, remember, as far as you go on this graph, the higher pitch, they fall off. As a matter of fact, they hear these sounds here, even though they're loud, because we're presenting them at 50 or 60 decibel, they're hearing them at threshold. So they can just barely hear this. So what's happening here is We get somebody, we give them this test and we give them words, and we look up here and look at their discrimination scores. They're 64 and 68% for the right and left ear. So even when we presented that sound to them at a level that they can hear good, they still only got 64 and 68%, because that's as good as they can do. That's it. That's the potential of how good they can do. When they don't have hearing aids in, they're out there hearing speech at 30% or 24, or, it's a much lower level. So our goal is to get them up at least this high. And sometimes it can even do a little better, but that's what we're really striving for. Now, again, if you look at those bone brackets, they're on top of the air conduction thresholds again. And that's because there's nothing impeding that. The middle ear is functioning perfectly. So if the middle ear is functioning perfectly, then the bone conduction is getting through at the same that the air conduction does. That's important. So that means there's no medical referral. It doesn't need to see an ENT. It needs to see one of us here whoever's doing hearing aids or monitoring the hearing loss or whatever, because there's nothing they can do. So that would be what we would call a good hearing aid candidate. So everything clear so far?
All right. So this one
All right.
is in a high frequency sensory neural loss.
That's right. It's a moderate high frequency sensory neural loss. Low frequency hearing within normal limits.
So with someone that has high frequency sensory neural loss, what sort of sounds might they miss?
Okay, that's a good question. I was going to address it later, but I think this is a good time to get to it. Let's move ahead a little bit. You see this right here? I hope you all can see that well, because that's a picture of the speech banana, and it tells you where sounds are. All of those sounds, you'll see at the bottom. Remember, again, everything down is bad, everything up is good. You look at this lawnmower, you see this helicopter, all those are super loud, and that's where they are on the audiogram. They're at 90 and 100 decibel. People who are profoundly deaf or who have severe loss can hear those things. When you move up the graph, you can see that the sounds get softer, but they are still down on the graph. And then things like leaves crunching, birds chirping, water dripping, those are sounds that everybody who has normal hearing can hear. But the interesting part is this part right here where letters are, which is where you're going. You can see that most of these over here are vowels. Most of these over here are consonants. And this is, I love this saying, but vowels give words power. Consonants give words meaning. Consonants are the brakes of language. They are what stop and start it. So if you're talking to somebody, they'll say with the high frequency hearing loss, if I'm talking to somebody with that high frequency hearing loss, then they're going to tell me many times, well, Jim, if my wife didn't mumble, I'd hear pretty good. And it, it's funny, we all laugh about, it's all your wife, but it is true. If it sounds to them like their wife mumbles or their grandchildren mumble, because they're hearing the vowels. Remember, that was on the left side of that graph. Mm-hmm. They're hearing the vowels great, but what they don't hear are the TH, the F, the S sound, the P's, all the things that are unvoiced. Or in speech, it's called fricatives. It's just air moving across the tongue and lips. And so when they hear things, it comes out like there's no breaks in the language. It's like people talk to me like this and I hear. They can truly hear me, they just can't understand. So if you're saying like if I, a lot of times I'll tell people with high frequency loss, I'll say, I'll cover my mouth and I'll say the words peach, keep, and thief. Well, they're all over the place. Beat, feet, they don't know. They just can't discern that word. They all hear the E sound because that's a vowel. Vowels have power, but they don't understand the consonant sounds because a TH and a K, are unvoiced. You can't hear that. So you either have to see the teeth going or the tongue going through the teeth to say "theep," or be able to hear it as best as you can. So you're going to get people who will just miss it. They'll misunderstand so much more than they think they do because they just hear what they think they hear. But actually, it's just them not being able to discern the differences in those soft sounds. And that's why we try to give, and technology helps a lot with this. We try to give them with hearing aids as much high frequency power as we can, but we don't want to give any low frequency power. And that's where advanced circuitry and stuff like that can help some. So when you like, if this person's doing anything, every time they go through life, it's always just can't understand, can't understand, can't understand. And that's why when you have high frequency sensory neural losses.
So let me ask, when someone gets hearing aids, and in this case, what are some things they tell you that they can hear now that they haven't heard maybe in years?
On this particular audiogram,
Yes.
they're going to tell you the leaves, the wind blowing, the clicks, any type. You can tell when they come in, they're like, oh my gosh, I didn't know the birds. I didn't know there were birds out there. There's so many things because they do hear, they don't notice the things that they don't hear. They'll sit out on the porch. They'll listen to the rain. It's just it's just a blessing to do this sometimes because you get to hear so many things that just change your lives. You don't know what you don't know. They don't know that they don't hear it. You bring it back on day one. Pardon? Oh, they bring it back on day one when we put the hearing aids on them. It's just like, wow, I didn't know the pen clicked. I didn't know that when I set something down, I made noise. I had a guy yesterday. He was just shocked that when he set something down on the desk, he could hear it. You don't know it doesn't make sound if you hadn't heard in 20 years. You just forget things like that. So here's where it gets fun. First thing you probably notice is a tympanogram. All of a sudden it got flat. What does that mean? It means the eardrum's not moving well.
That first graph up there at the very top.
Yep. First graph, that tympanogram. It should be a mountain, but it's not a mountain. Now, so we know then that the eardrum is not vibrating like it should. And now I go down to my graph and I look at, remember I said there's two ways to test, well, speech too, but mainly it's pure tone air conduction, headphones over the ear, or bone conduction, vibrator on the mastoid. You see this right here? These are those bone conduction thresholds. These are the air conduction thresholds. Now the brackets and the circles and X's aren't on top of each other like they were right here. See, there's a separation now. See where it says air conduction thresholds 15 dB worse than bone conduction. So what this is that when we present something to the ear, it makes it through here, okay, probably, but somewhere in here, either behind the eardrum or in this ear canal, is a conductive loss. So in this case, that person probably has fluid in their ear. So it caused them to. So that dampened the air conduction thresholds. The sounds had to be louder to get through the hearing mechanism. But once we did the air conduction thresholds, then I put the vibrator on, and darn, I've got hearing within normal limits. So that tells me that even though this isn't functioning like it should, this cochlea, the inner ear, is. That's normal. So we've got what we call a conductive loss. I'm going to get that over to the ear, nose, and throat. We may be looking at tubes. We may be looking at just some antibiotics, whatever. We'll see back in a month. Then we'll retest. All right, now I don't want to lose you here. Does that make sense?
Yes.
Okay,
It does
good.
to me. If anyone has any
Good.
questions, please jump in.
Because this is not easy right here. I'm not kidding you. This throws a lot of people. And now just because it throws a lot of people, I'm going to even make it a little bit harder. Um, you'll notice here that the speech thresholds are all elevated. There's no nerve deafness because the bone conduction's good. So the speech discrimination should be good if it's loud enough. It should be good if it's loud enough. And that's exactly what this shows. Look how much better the speech discrims are, 88, 92%. That other loss a while ago was at 68 and 64%. But because the inner ear is still good, we expect with louder sounds that the speech discrimination would be good, and it is. So everything in my cross-check principle, everything works like it should. Flat temps, this, and my audiogram is going to say consistent with fluid. All right. This is as hard as it gets here, and then we're cruising. This is a mixed hearing loss. The first thing you notice is that darn temps are bad again. So I automatically know going in that I'm probably going to have some kind of pathology in the middle ear. And we do, or in the ear somewhere. So here's what it is. This time, this is mixed because these brackets that you see are below the hearing within normal limits. They're in the mild range. The air conduction thresholds are now in the moderate range. So everything in that graph we saw a while ago has moved down and gotten worse. So what we can say here, because it's got damage here and in the nerve, that it's mixed. It's got both. It's covered both things. So now I can say, what could be caused? I know this is bad. I don't know why it's bad, but I know it is bad. But what could be causing the conductive component? Do I need to get that to the ear, nose, and throat doc? Well, it happens that I happen to see the wax in my office. So I said, oh, well, we'll just get the wax out. So I get the wax out, put him back in the sound room. Oh, test him again. And I get something that looks like this again, but the air conduction thresholds are, I'm sorry, I'm so sorry, but the air conduction thresholds are up here. So what we've turned up, if we clean the wax out, we've turned a mixed hearing loss into a mild sensory neural hearing loss. Does that make sense? Because I can explain that again.
Yeah, so that having that wax in the ear can affect the type of hearing loss that someone has just because of the way it's affecting the ear or how
Yeah,
far it's down it is.
yes. In other words, when the air conduction gets, if you've got a mixed loss, that air conduction, if it gets fixed, it will go back to what the actual sensory loss is. It doesn't mean it's going to make it normal hearing, but it is going to go to where the bone is. Because the wax creates this. The nerve creates the loss here. And I know that's difficult, and don't worry about it if you don't get a great understanding of it, because it is hard. And it can show up in many different ways. These things can be all over the page. But what we're trying to say is, though, mixed loss, when you see a separation, anytime you see a separation of air and bone, you always have a conductive component somewhere. And that's what we need to find out on our end.
In those cases, do you usually refer them to an ENT, or do you have to do a little more? Okay.
I usually do. Just because I don't see as well as I used to, and there's no sense digging in there for wax when I don't have to now. A lot of urgent care takes care of them too. Yeah. So it's real easy just to get them to do it. They typically doesn't take them long either. But the thing is, anytime I have a mixed hearing loss, there is a potential with a mixed or conductive that it can be fixed. We don't look at hearing aids first. We look at hearing aids second in that situation. And if it's conductive, we don't look at them at all. Remember, conductive losses have normal low frequency, have normal hearing in bone, Mixed losses have abnormal hearing and bone. That's the only difference. There's a gap in both of them. But you see how there's still a gap here,
Mm-hmm.
and there's still a gap here, except this one, the bone is in the normal range. So in both situations, if both of these patients had wax, well, I'd get done with this one and I'd say, okay, well, the wax is good. You got normal hearing. I get done with this one and I say, well, the wax is gone now, but you're still left with a little bit of a mild permanent hearing loss. Because even when I cleared this bone gap up, it still got below 20. We good?
Yes.
All right. All right, good. Well, I know that's complicated. You should have seen us as students trying to figure all that out. Masking is, you'll see a lot of times where we mask for to get the ears more exact. All that means is when sound gets loud enough in one ear, it will vibrate to the other ear. So if I turn the sound, let's say you got a 60 decibel hearing loss on one of your ears, and and the other ear is normal. If I'm starting to test the bad ear, the good ear will start hearing it because it'll cross over. So what we do is we just put masking noise in to prevent that from happening. But it's nothing really you have to worry about. It's just something that is there. Again, here's the speech banana again. And like I said, this is really important as far as words, why people with high frequency hearing loss do poorly. It's because they can't understand consonants. It's like uh, if I say like I told you a while ago, the word thief. If I say that word, I just know that it could be so many different words. If you can't hear sounds like F, T, H, S, C, H, P, all those sounds, you've just got to be able to hear. When the hearing loss gets worse, like even this hearing loss here could be like start here and drop way down to here. If it drops down to there, the speech discrimination gets worse. Their chances of doing better get worse, but their hearing loss is a lot worse. So it's just adamant that we get these people treated as quickly as possible and get the best care they can. It's terrible when you have hearing loss and you're left out of communication. It's the worst thing. Uh,
So we have one question.
yep,
If someone is having a problem understanding people, like when they're in a group and there's,
yep,
multiple people are talking, would
yep.
you recommend they go ahead and get their hearing tested?
Oh, absolutely. Absolutely. Yesterday, get it done. We are seeing so much. I'm telling you, Ashley, when I started this years ago, I didn't think I've got 10 referrals a year from a general practitioner. Now we get them, it seems like every time we turn around, because we know that hearing loss left untreated, bad things just happen. You don't go deaf. I have people all the time say, well, they told me I was going to go deaf. No, you're not going to go deaf, but it's one of those things that you don't lose it, you use it. You've got to stimulate those ears. Your greater chance of aphasia, a greater chance of dementia, Alzheimer's, all that stuff. If it left untreated, we want to get it treated as quickly as possible because it's not going to keep you from having those things, but it's going to slow it down from having those things. So yeah, you just want to get it. We want to get it taken care of, and it's always going to be those are the two red flags. Can't hear in background noise. Can't hear groups of people are talking. And that's again, it's because they just don't have those. The noise is louder than those PH and TH sounds that they hear. Um, Chances of success. This is a good little slide. Uh, the most important factors for success with a sensory neural hearing loss. Patient motivation. They've got to recognize that it's on them. So many times they want to blame somebody else. But the greatest thing about sitting in the office is just talking to people. We can help them to see that. We break down the charts. We show them how they missed the words of the graph. Um, we do all these things that can help them to come to terms with what they're actually dealing with. I always love to see high speech discrimination scores because I know they're going to do pretty well with their hearing aids. Um, Putting the hearing aids in, you got to get them in right. So many people aren't trained in how to do this. They've got to go past second bend of or the first bend of the ear. They've got to be put with the right size. They back out on people. You just got to do so many things right, and they be kept clean. They get the ear canal is a pretty nasty place, and they get dirty so quickly, and people just don't come in like they should. So you need to follow up. Tell your friends and relatives if they've got hearing aid, follow up, follow up, follow up. So that I think, yeah, that's just the type of hearing aids. So that should leave us time for any questions or answers or questions and answers that we can do.
So when do you
And I may have
recommend that
already answered them. I
people,
don't know.
when do you recommend that people start getting their hearing tested? You know, as a child, as an adult, what is your thoughts?
Just as a child, and the school system does great now at this. We get newborns now. They're tested within 3 days at the hospital. If any of y'all have recently had a baby, they do hearing tests. That's done with electrodes and all. But yeah, we're starting them out right out of the womb. And then, in high school. And then if you ever notice any problems, like I said, general practitioners have gotten so much better because a lot of times in a clinic where I work, I've got 2 or 3 doctors that screen people now for hearing loss just when they come in for their regular appointments. They just do a 4-tone, 4-frequency pitch screening, but it tells us that they may have some problems.
Okay.
I'm sorry.
So after school and they no longer have access to those types of preventative services, should a person get their hearing tested other than at red flags, maybe every year, every couple of
No,
years?
no. It doesn't need to be that often, but it does need to be when they notice any type of changes, when they notice they just start having a little bit of difficulty. But they've got to, as long as they go to their doctor regularly, if you don't go see your doctor, then yeah, you need to come in every once in a while and get your hearing tested. But as long as you're going to doctor now, hopefully your doctor, whoever it is screening for hearing loss. Now, if they don't do that, I would say at least it wouldn't hurt every 5 years to come in just to make sure everything's okay.
So we have one question. They had sent a person that wasn't able to understand someone that was speaking in a crowd, and the audiologist said that their hearing loss, that there was no hearing loss, even though there was significant issue with background noise. Can that be
Yes.
caused by a different condition like
Yes.
ADHD or something similar?
What did you just say? What did you just say? See something?
Oh, I was going to
Oh,
say
ADHD.
yes.
Probably more, I would say central auditory processing is usually that issue. They just can't attend to, they don't, they'll usually present themselves with like not being able to follow. They might get the first part of a message, but not get the end. They're constantly looking like they're not paying attention. And it's a lot of times it's confused with attention deficit because, but you'll notice if I said, Andrea, run over there and grab me the specula and some napkins and a sponge. She might go and get the specula or the sponge or whatever the last thing she heard, or maybe just the first thing she heard. She couldn't attend to all 3. And that's just more like, and the sad part is we used to test a lot for that, but insurance, of course, quit paying for it. And now I think there's only somebody in Louisville that actually does CAP testing now.
Okay.
But yeah,
And
it's
so
not that they're not lying.
what do you do when you suspect that maybe it might be a processing disorder versus hearing loss? What are your recommendations usually?
It's a big if it's processing disorder and they're still in school, then I'm going to recommend an FM system 100%. Nothing helps better. Actually, everybody would do better if FM systems were in school. It's one of my pet peeves. I would like to see them in all classrooms, but especially kids who have ADHD, attention deficit, CAP. It's just a shame we don't have that kind of technology where a teacher just wears a mic and speakers are in a classroom, and it would just be so nice. But, and I tell parents, I go, go to the school system, fight for it. Talk to the speech and English pathologist. They'll help. They understand, but don't just say no. There's nothing they can do. Now, once you're out, it's just hard to, have a workplace where you have to learn to kind of cope. But getting your education, I'm just a big proponent of it. You got to have it.
Is there any treatment available to your knowledge for auditory processing
No,
disorders?
no. Sadly, no. It's like tinnitus. It's real, it's there, and it's frustrating, but there's not really anything other than hearing aids with tinnitus. But yeah, that's pretty much it. Not much you can do.
I've
Now,
had
look,
audiologists recommend hearing aids for people that have tinnitus
oh yeah,
as part of
yeah,
management. Do you
yeah,
see that quite frequently?
yes, yes, yes. I'm a big proponent of it too. But here's a problem. And it's we don't know why yet. It works for some people so well and some it doesn't. There's just no way to know for sure. But some people, when you first put the hearing aids on, you can just see their whole body relax because they just, oh my gosh, it's so much better. And it's just horrible to deal with. Then people just have a really hard time with tinnitus. But other times it doesn't. For some reason they'll say, no, I still hear it the same. But we always try to get somebody who's got tinnitus at least to put a pair of them on and just chart to see what the percentage of improvement is. And even if it doesn't improve that much, we can present, if you're hearing a shrill 3000 hertz all the time, every second of the day, it's going to get pretty irritating. But if you can present a masking noise or a narrow band noise that is a soothing effect, like water running or something, like a waterfall, that can mask it, sometimes that can be a big help. We don't try to let anybody, we always try to offer something, but sometimes there is nothing, like the CAP with the CAPD. Um, sometimes there's just not much you can do. But I would encourage anybody who's got a child with that to definitely look into the school system and also get evaluated. I don't do it anymore. But from back in the day, I know some people did really well. If you and probably a speech and language pathologist could help a lot with that too, because they can present different learning strategies, or an academic therapist, somebody that can help them cope with other ways to learn.
So when we have consumers come in, there's a lot of times we have to have a conversation about hearing aids and expectations.
Yes.
I think there's a lot of times they come in thinking that maybe hearing aids are a cure. Do you ever run into that, or how do you address that?
Yeah, I pretty much addressed that when they first come out of the sound room. I'm going to say, look, this is going to be, if you'll do what we tell you to do and you follow the instructions like we're going to show you, this is going to be a real game changer for your life. You'll wish you'd done it 20 years ago. We see it all the time. I wish I'd done it sooner. Wish I'd done it sooner. But you got to pair it with realistic goals. You can't say, if I can put somebody in a $10,000 room and I test their hearing and my discrimination score is 64%, they're not going to do better out there in the environment where there's noises and everything than they will in a $10,000 sound room. And I get aggravated when people do say, oh yeah, you're going to hear, perfectly, because you're not. We're very good. We're very good about giving people realistic, because that's what they need. That's what they need. And it is a big deal for them to say, oh yeah, I see what you mean now. Yeah, I do. It is getting it. And they all get used to it, but they've got to stay with it. I mean, people say, do I have to wear them all the time? And I'm like, yeah, I want you to wear them all the time. You got your ears on all the time. My ears are on all the time. Wear them. Your body will wire itself to us. Your brain will wire itself, but you got to follow up with your provider and let them know what's going on.
Speaking of that, how often do you see an adjustment period for people? Some adjust very quickly, some it may
Yep.
take a longer time. What
Yep.
do you recommend us providing guidance for our counselors on
Yeah,
that?
that's right. Some of it takes, I've had some time, I can just give you general statistics. Uh, 14 days is usually the part where it takes for the voice to get their voice to feel like it's better, and for them to start acclimating to sounds really good. About 14 days, they'll forget they have them on. They'll say, oh, I didn't even remember putting them on this morning. Uh, Sometimes it takes to 30 days. Every once in a while you see 90 days, but here's an interesting thing, Ashley. If When you amplify sounds to somebody who's hearing impaired, if they've got a sensory neural loss, not only do they not hear soft sounds very well, but they can't tolerate loud sounds very well. Their range of hearing is reduced. So where a kid may hear everything from 5 decibel up to 110 decibel and be fine, somebody with a damaged auditory system is going to hear from maybe 40 decibel up to 85 decibel before it's too loud. So they just have a reduced range of hearing. And you got to try to fit hearing aids in that range. And sometimes that takes 2 and 3 visits to kind of get that all tuned in. It's psychoacoustics. It's how do people perceive sounds. And,
And then
for whatever reason, I can't stand the sound of nails on a chalkboard, but my daughter can't stand styrofoam, So we don't know what the psychological reason that is, but believe me, it's real.
I know that we had one counselor put in for auditory processing disorders. Some of the things that we can talk to our consumers about or recommend is auditory training. There's some hearing aids that can help filter out that background noise and amplify speech, talking about the environment, and then having classroom supports like those FM systems.
Yeah, that's the game changer right there. All the rest of it's just, look, different learning strategies is good. Like I said, I used to be on top of all of them, but I haven't done it now in 10 years. So yeah, if anytime you can teach somebody better strategies to learning, it's going to help. So I'm not sure what the latest thing is, but I would definitely highly encourage somebody to do whatever they could for their child like that.
So with all the people you've seen, what are some instances that are some reasons that people have experienced sudden hearing loss?
Yeah, it's good. You know the word medical term idiopathic. You ever heard of that?
Mm-hmm.
Yeah. Well, the root word's idiots. Sometimes we just don't know, and it's just that simple. It's you can wake up one morning, and I've seen it times it scares me to death sometimes thinking about it because I've seen people just wake up. I had a 24-year-old guy wake up with a profound loss in both ears, and no idea. I
I had a
mean,
consumer like that.
Did you?
Mm-hmm.
Oh, it's horrifying. They're a basket case. I mean, this guy was he was just in, and I don't blame him. I had to send him down. We sent him down, I think, to Shea Clinic in Memphis and tried for something, but it's just sometimes it just happens. I had a guy probably 3 weeks ago, just sudden onset, lost one side of his hearing. Hadn't no reason. I mean, when it's a child and stuff like that, you have mumps and things like that can cause it. But usually it's a virus, some type of virus that you never know. But I do know this, if it's sudden onset and you get to a doctor, and that ever happens to anybody here, if you ever wake up one morning and it's just suddenly gone, you get into an ear, nose, and throat clinic as quickly as possible, because if you can get there soon enough, there is a chance that a shot that's steroids can restore it if you catch it soon enough. So you got to tell the receptionist, need it today.
We've had a couple consumers that have had loss because of COVID. And then I had one who was a truck driver who woke up one day with complete loss on one of his ears, and he went for test after test after test, and they still to this day don't know why he lost that hearing.
Yep. It's tough. The worst thing that I see happening is they go to, the patient doesn't know. They don't know if it's not fluid. They think it's just fluid. But they go to the doctor, and the doctor says, oh yeah, I see fluid in there. Doctor puts them on antibiotics. So they mess around for 6 or 8 weeks, treating them with antibiotics. They never get better. Then they come in the ear, nose, and throat clinic, and then it's probably too late. So I'm saying always get to the specialist if that ever happens. Because, you can't expect the GPs to know that, too. That's pretty rare.
Is it best to be referred to an audiologist by your primary care physician, or just to call up an audiologist and say, hey, I'm having some hearing loss?
It is now, because the best go straight to the audiologist, because insurance has gotten so darn hard about getting referrals in, and we can just refer, get it in a lot easier.
Yeah, and we'll know. That has to do with insurance.
Yeah, I mean, I probably would anyhow go to the audiologist because, like I said, 80% of the time it's in our realm, 80%. So it just would be easier to do that too. But like with insurance, the way it is, and the way we're a good gatekeeper for the ear, nose, and throat. That way they don't get too plugged up with stuff that they don't want to work with enough of them. They don't want to be a glorified Q-tip.
Are there any treatments for tinnitus that of besides, hearing aids helping?
Oh, I know of some, but I don't think they help. I just don't think, I really don't think they help enough. I think there's a great episode on This American Life the radio show about a guy who got upset because his doctor told him to go home and deal with the tinnitus because he couldn't do anything about it. Well, he goes down a rabbit hole and starts finding all of these different theories that, treatments. And he spends 2 years of his life traveling all over the world, trying all this stuff out. And he ended up at the end of 2 years, he said probably the most compassionate thing that anybody ever did was told the doctor should have just told him to go home. He could have dealt with it psychologically and been where he was. Now, that I understand that. Now, I thought that episode was a good episode, but before you get to that point, I think you ought to do everything that legitimately can be treated. And I don't think the pills, there's nothing in the pills, but I do think some biofeedback, some just getting relaxing techniques, don't get on the, just learning therapy, even some cognitive therapy will be good. That can help you to learn to deal with this better. Because more often than not, people, if you can get them through it, they will acclimate to it. I mean, it may take time, but they will acclimate to it. But we know for a fact that the higher the inherent neurosis is in the individual, the greater the chance that it's going to bother them when they do have tinnitus. So it's just a lot of but I would definitely try hearing aids, and I would definitely maybe a masker if that, they need that. And then after that, maybe some support group or something, whatever can do to help. But there's nothing, I wish there was.
I have counselors saying that they've seen an increase in hearing loss and reports of tinnitus since having COVID.
Yes. Yeah.
Do you think that's why you all have seen such an increase in referrals?
I don't know. I mean, it's so hard to know. I just really, I can't tell you for sure. I don't know. I think it could very well be, though. I mean, I could see that being a distinct possibility. It's affected everything else. I feel like it's affected me when I got it. So, I could see it doing anything. But, without being there at the time, if they said it would happen right when they got COVID, then I would say, yeah, that's probably could.
Right. And
Do you
then,
have,
go ahead.
how deep do you delve into history on the hearing impaired people that you all see? Do you get pretty deep into their history on hearing loss, or do you just, or about like I do, or what?
Well, we actually do a communication assessment with them, and it's about 10 to 12 pages of a lot of different questions asking them about not only their work experience, but if they're in training environments, how long they've had
Good.
hearing loss, just to kind of get an idea of what's going on. Some of us that have been doing this for years will ask questions like, did you have problems if you were a child? Did you have frequent infections? Was there any sort of trauma? So I think it's a little bit of a learning curve. Some of us have learned to ask some of those questions. Some of us are still learning to ask those questions
Good.
because we see all these links between different things, like the question I asked about the tubes and the scar tissue.
Yes.
I never knew that was a thing until I
Yep.
started working with people that had hearing loss, and they just kept reporting that over and over again.
Yeah, sclerotic plaque, and it's right on the eardrum, and it's real, and it just makes the. Remember, I said something about the eardrum vibrating, and it just caused the eardrum to not vibrate. Got a conductive loss or a mixed loss. Yeah, it's a real deal.
I have one more question last on my end.
Okay.
Um, what are some things that may cause someone to have fluctuating hearing loss?
Meniere's disease is a biggie. Meniere's. It's absolutely, you can't, it could be down one day, it could be up the next, it could be go away for maybe 3 months, it could come back, it could go into one ear, it can affect the other ear. Anytime you see fluctuating hearing loss, if it's not related to middle ear fluid, where the eustachian tube's opening and closing, it's going to be more than likely Meniere's disease. And that's a pressure change in the cochlea, pressure variances differences. Why do you know somebody with Meniere's? Or it's pretty brutal, actually.
Yeah, I think I've met maybe just a handful of people.
Yeah, because it makes it really hard doing hearing aids with them because you can set up programming, but the programming you set up on Friday may be totally different by 3 weeks later. So it's sometimes I feel like we're chasing our tail on that.
Do you guys have any other questions, comments? I know you guys have sent me a lot. I feel like I've done a lot of talking, but now that we've got Dr. Browning here, please feel free to ask any questions you may have. And as I said that, I got another question.
Okay.
Are there times that you feel that a patient would benefit more from having like a cochlear evaluation or a Baha
Yeah,
evaluation as
yeah,
opposed to a hearing aid?
yeah. I do sometimes, and I'll just tell them. I'll say, "Look, we've gone as far as hearing aids can go," and they don't want to hear that. They do not want to hear that they can need a cochlear implant more often than not, because when they start finding out, they realize it's a pretty big deal. But sometimes you just can go. You only can go so far. Now the Baja, I see more of that in the clinic. I don't see that in my office. Uh, it's just uh, if they've got a severe conductive loss, though, it can be a game changer. But a lot of the surgeons just aren't that I work with, just don't do it. They just rather just put because honestly, you do pretty well with the conductive loss with the hearing aid, so that's typically where they go. But cochlear implants, I mean, I've seen them. It's kind of like with tinnitus. You never know how good they're going to do before. Sometimes they can do great, but sometimes they don't. And I see them both. Do
We've
you
had
deal
a
with
couple.
anybody with cochlear implants? Do you have people that you deal
Yes.
with? Yeah.
We actually assist with cochlear implants, and so
Oh,
we work with
really?
a couple of surgeons across the state. But they have to have a cochlear implant evaluation, a hearing aid evaluation, or
Yes.
yeah, a hearing assessment. And both have to
Yes.
agree that the
Yes.
cochlear implant is the way to go,
Yeah.
and then we move from there.
Yeah. That's what they do us. They actually have to try the hearing aid first before they even get the cochlear implant.
And a lot of that is dictated by insurance. And there's one comment how frustrating it is dealing with insurance and how it can dictate how you treat someone, which, we've all run into that. I can't imagine it being a provider. It's
It's
must be
awful.
incredibly frustrating.
If you want to hear me just rant terribly, I just give me on insurance. It just uses up so much of my time, the office time, to trying to get. I mean, like I said, we've got people here that can help with that stuff, but it's brutal. And actually, you're right. It actually controls healthcare.
And then we've had one comment, someone lived near a busy street, and because it was so loud, it caused them to have tinnitus at that time. And when they moved, it actually cleared their experience up because they
Really?
weren't subject to all that loud noise
Yeah.
constantly.
Yeah, that's called a temporary threshold shift. When
Yeah.
you're around a lot of noise and you leave, a lot of times while they're there, they'll have ringing in their ears for a while after they leave, but then hopefully it goes away and, and it's a temporary loss. Yeah, that's good. Glad they got
Any
out of
other
there.
questions, comments, concerns? Because if not, I'm going to let Dr. Browning go. I think we've covered a lot of things, asked a lot of questions, and got a lot of really great information.
I hope
I
it did. I hope
Yeah.
it made it easier to understand because I know how hard that audiogram is to look at and make sense out of.
Well, you've already got positive comments saying you did an excellent presentation. Thank you. Great
Thanks.
presentation. I really appreciate you taking the time. And if you guys have any follow-up questions, you can always send them to me and I can get them to Dr. Browning and
Yeah,
we can
call
touch
the
base
office.
again.
I mean, here's the thing about it. We've got three people here, James and Andrea and me, and we telecommunicate. We all communicate with each other. If you're ever with somebody, and then I don't care if it's our person or not, and you want to find out some information, just call us. Even Bonna, she's a receptionist. If all three of us are tied up, then get Bonna. Well, we can answer anything. If you're in a situation where you need help, just let us know.
And there have been times I've called and just asked technical questions because there's something that I didn't understand. And you guys have all been very helpful, and I appreciate that very much.
Yeah, it's really a fun time now to be doing hearing aids because of technology with the Bluetooth and some of this AI coming out. It's really going to be an interesting. It's a little early yet for it, but it's going to get interesting the next year or two.
Yeah.
Hey,
Oh,
thanks,
I've
Ashley.
got
It's been a
one.
pleasure.
All right. Just one second. I got a question. They're typing it
Okay,
to me. I'm waiting for you to type quickly.
that's okay. I'm in no hurry. I'm here till 5 o'clock.
How do you handle medical clearance referrals?
uh, well, actually, I hate handling medical clearance preferred. Here's the thing: I only have to do it for UMWA. Are they doing it for something other than that?
I know that we have had some vendors, some of our providers that will tell people, okay, this is what we have found, and we really think that you should see an ENT or follow up with this provider. And of course, it's consumer choice if they want to or not. So
Right.
they can waive that decision and sign a
Yes.
form, and
Yep.
we're good to go. And then some people are want to follow up.
Yeah.
So I
Yeah.
believe that's sort of what she may be talking about. But is that something
Yeah.
that you run into?
Yeah. I mean, I really try. I- When I send somebody out, I really try to get them to follow. I mean, they usually follow all the advice stuff that we give them, but I would try to give them, look, it's probably not. It looks, I mean, I've done this a long time. Most of the time it's benign, but I really think you need to get it checked out for sure, just so we know. It's a comfort thing. And then when they do, the ENT, the doc, whoever it is, will almost always send me back a medical clearance with dictation, just to make sure that they decided to do whatever they want to do, treat it. But it's never been an issue for me. Has it been for them?
Well, we've gotten records back saying that the consumer needed medical clearance before they can move forward with the hearing aid evaluation.
You got to be kidding me.
Uh, I've seen it a few times myself, but I can see
Huh?
this person is in a whole different area and they're seeing it too.
Huh.
So I don't know if it's a new recommendation. I don't know if it's something to do with the ear or the individual themselves, but I've seen it a few times
Well, I'll
myself.
be darned. No, I've not had that. God, I hope I don't either.
Well, glad to bring it to your attention. It might be
Yeah, now,
something new.
another thing to dread.
If someone does not have insurance or their insurance does not cover hearing aids, how do you typically deal with that?
Yeah, that's a good one. Uh, the first thing this comes all in that first meeting when I sit down before I start the hearing test. I try to qualify what their status is. If they do not have insurance, and many times they don't, sadly, um, what we try to do is one of the things we'll mention is voc rehab. I say, are you looking for work? Are you trying to find a job? Are you looking for work? Has that been an issue for you? And they'll say, whether they have or not, or what their job's like. Because I said they can help you, to keep a job, hold a job, keep a job, and stuff like that. Because by the time they're in my office for hearing aids, it's a pretty big deal. They've been hit at by everybody, by their family and friends and kids. So that's one option. The other option is we try our best to find a way to fit everybody that we can. Sometimes I keep used hearing aids here, have them reconditioned, and try to get something that they can afford. That's just because on those, even at least I can take a $40 a month payment or $50 a month payment for 4 or 5 months, and you know, get them something. Something's better. Something custom fit is better than anything not.
Right. And I mean, we run into the same thing. There are some people that are just not eligible for our services, and we have a couple of, we can always give them loan options. And there's I think it's the Appalachian Assistive Technology Loan Program where they can apply for a loan for up to $7,000. They have 4 years to pay it back. It's zero interest rate, and it's toward assistive technology. And so, but funding options in Kentucky are very limited.
They're
But
very limited. Used to have Here Now, and they were wonderful. But yeah, I don't. We do care credit, but sometimes I hate going that way because the interest rates are high. But we can usually find somebody that's going to give us a low rate and work around that way.
all right. Well, thank you so much for joining us, and I really appreciate your time, Dr. Browning.
Yeah,
Thank you,
thank you.
all
It's been
counselors
fun.
and staff.
Yeah, it actually has been fun. I've enjoyed it. Thanks, Ash.
Thanks. Bye
All
bye,
right.
everybody.
Bye bye.